Module 6, when mammography is not the best option. For the personal privacy of our peer educators, they are clothed in camisoles during the demonstration of each exam technique. Here, our peer educator Susan and our duo of technologists work as a team to attempt to position and image her breast tissue in multiple ways without success. Susan's mobility limitations, related to her cerebral palsy, do not allow Susan to straighten her spine, rotate her torso, or adequately raise her arm to permit optimal positioning. Rather than attempt more images, the radiologist is consulted and the decision is made to perform an ultrasound exam, as it provides flexibility for imaging those areas of the breast that cannot be adequately included on mammography due to mobility limitations.
So I've looked at the images that Kathy and Vicki have taken so far, and we've got good pictures of the front part or the most glandular portions of your breast, but we haven't included enough of the posterior part. So I'd like to do an ultrasound.
The technical advantages of breast ultrasound include the ability to modify positioning of the ultrasound transducer to accommodate the physical needs of the patient and image the breast without additional radiation. There are currently 2 types of breast ultrasound: handheld ultrasound, automated whole breast ultrasound. The handheld technology may have more flexible use for many patients with disabilities. Currently screening breast ultrasound may be indicated as a supplemental exam for women with heterogeneously dense or extremely dense breast tissue on mammography, women who are at elevated risk of breast cancer who are not candidates for breast MRI, and women with newly suspected breast cancer. For diagnostic evaluation of the breast ultrasound continues to be a commonly used imaging method. Indications for diagnostic breast ultrasound include evaluation of palpable breast masses, abnormalities identified in mammography or other imaging, problems associated with breast implants, signs of breast infection, axillary lymph nodes, and evaluation of the breast in pregnant and lactating patients. In general, breast ultrasound is performed with the patient in the supine or semi-supine position. Here, our technologist Kathy assists our peer educator Kimberly in getting into the proper position. Our technologist asks her patient to raise her arm above her head and to turn slightly onto her right side in order to perform the left breast ultrasound. The technologist uses a foam wedge to help her patient maintain a slight decubitus position. This positioning allows better spread and stabilization of the breast tissue when scanning the breast. Once in position, the technologist will apply a water-soluble gel to the transducer, which allows optimal contact of the transducer with the exposed skin to transmit the sound waves through the breast tissue. The technologist guides the transducer along the breast tissue, scanning systematically, covering all of the breast. If a questioned abnormality is identified or if the patient has a focal palpable lump, the technologist will focus on the area, obtaining images in multiple projections to characterize the finding. Additional imaging of the axillary region may be included as part of the exam. Although ultrasound of the axilla is best obtained with the arm raised, if the patient is unable to elevate her arm, the small size of the handheld transducer can facilitate imaging with the patient's arm down. Some patients may not be able to safely transfer to a cart or exam bed or maintain a supine position. In these cases, an ultrasound may be attempted with the patient remaining in her wheelchair or scooter. Some patients may have a wheelchair that reclines or tilts in space. When the patient is seated, access to the upper and outer breast, as well as the axilla, is best accomplished by having the patient extend and rest her arm on the technologist's shoulder. Depending on the strength and mobility of the patient's arm, she may be able to raise her arm and rest it on her head, thereby providing access to the axilla and spread of the upper breast tissue. In those cases which the patient's upper extremity mobility is limited, a second technologist or assistant may be helpful in supporting the patient's arm. Recall from the safety module that when rigidity or muscle spasm is the reason for the immobility, the arm should never be forced into position. However, to best examine the lower portion of the breast, the patient is asked to attempt to recline slightly in her chair while the technologist lifts the breast and scans the inferior portions. During this positioning, it is important to make sure the patient remains in a stable position in her chair. The other alternative to handheld ultrasound is the more recent automated whole breast ultrasound technology. the breast is scanned with a larger transducer format mounted on an articulating arm, which is guided by the technologist. Performance of the exam requires the patient to be in a supine or slight decubitus position with her arm raised over her head. The image of the breast are acquired generally by 3 to 4 scans over the center, inner, and outer portions of the breast. The images are recorded on a computer and can be formatted in different planes for interpretation. The positioning required for automated ultrasound of the breast may limit the utility of this technology for some patients. There has been no published study on the effectiveness of breast ultrasound as the only screening breast imaging exam for women with disabilities. However, the Akron study showed an incremental breast cancer detection rate of 4.2 cancers per 1,000 women who had dense breasts, a negative mammogram, and were at increased risk for breast cancer. This study did not address the benefit of screening breast ultrasound for women whose breasts are not dense on mammography or with no known risk factors. The challenges of screening breast ultrasound include the length of time to perform the exam, mean time of 10 to 20 minutes, and the reported high false positive rate. The Akron study reported a positive biopsy rate of 8.8%. While not indicated for a case like Susan's or Kimberly's, MRI may be an additional supplemental screening exam for some women. Screening breast MRI is generally recommended only for women at significant increased risk for breast cancer, including proven carriers of the BRCA mutation, untested first-degree relatives of proven BRCA mutation carriers, women with greater than 20% lifetime risk for breast cancer based on family history, women with history of radiation therapy involving the chest, such as lymphoma, women with newly diagnosed breast cancer and normal mammogram of the opposite breast. May be considered in women with 15 to 20% lifetime risk based on personal history of breast or ovarian cancer or biopsy-proven lobular neoplasia or atypical ductal hyperplasia. Additional ACS guidelines include not appropriate for women with less than 15% lifetime risk, does not replace mammography, but performed in addition as some cancers, DCIS, may not be detected on MRI. Considerations for the patient when performing a breast MRI include patient positioning, which requires the patient to lie flat on her abdomen and remain still. Some patients may experience claustrophobia. Important to time with the patient's menstrual cycle, days 7 to 14, as there can be increased enhancement during the secretory phase, which could cause false positive results or interfere with the sensitivity of the exam. Hormone replacement may also cause increased enhancement. In addition, the exam requires an intravenous injection of contrast. It is required to identify any tumor based on its vascularity. Such contrasts may be contraindicated for patients with history of allergy and/or kidney disease. Regardless of screening method used, patients should work with her primary care provider to determine her individual screening schedule and best screening method. Although clinical breast exam does not replace imaging, a clinical breast exam should be performed by a primary care provider as part of the women's wellness care. Critical success factors in the early detection of breast cancer for women with disabilities: quality mammography or alternative imaging, effective communication and education, partnership between the patient and healthcare providers, an atmosphere of comfort and safety, yet one of empowerment for the women with a disability.
The person is always most important. I'm here for them and to take care of them, and they will tell me what they can do and they cannot do, and I'm here to listen to them, and they will provide me instruction. I am there for the patient.
The best piece of advice I could give to a new technologist is to treat every patient as a human being and to focus on their ability and not their disability.
My best experiences were basically being treated with respect just as a woman.
It takes time for people with disabilities to get the exam done. And I think meeting them at their level, like she sat down with me instead of standing up, that's actually a respect for my mobility and how I get around.
I will tell every technologist to listen, to have patience, to hear us as patients with disabilities. We matter.